Okay, so this is topic rare mutations. And so my disclosures. Okay, so precision oncology has changed the classification paradigm of non-small cell lung cancers. We are sequencing, thankfully, most tumors, all lung adenocarcinomas, and really it's created the ability to characterize these tumors rather than just histologically, by molecular defined subsets that have actionable targeted mutations. And so for lung cancer, KRAS is the most common molecular subtype, followed by EGFR. EGFR really cleared the pathway, as discussed earlier, for really this targeted approach. But importantly, the frequency of these driver mutations is highly variable according to different race ethnicity, as you can see by the outer and inner curves, circles on this chart. And so while many actual mutations are relatively rare, if you look at it, these are the tumors, these are the mutations we're talking about, where collectively they make up quite a large percentage. And importantly, the number of drugs that are now available, that are being studied, that are effectively targeting these tumors, these molecular driven tumors, is really quite impressive at this point. And so they're mostly being studied and approved in the advanced setting, but they're starting to be moved up front to the early stage. So we talked about EGFR kinase domain mutations earlier. The most well-known are the exon 19 deletions and the exon 21 L858R substitutions. These are considered the classical mutations because they are highly sensitive to first and third generation tyrosine kinase inhibitors. So data really, has been coming across over the last decade or so, but the FLORA trial really established osimertinib as the first line choice for this molecular subtype. And so, not only by responsiveness, but it's a well-tolerated drug. Some diarrhea, some skin rash, but easily manageable. Patients do really well on this drug. And as we discussed about, using EGFR TKIs in adjuvant treatment settings, this was done before ADAURA, right? And so this Chinese study looked at gefitinib in this case, right? And so there was a really important question that was being asked, because we don't think in the advanced setting that TKIs are curative, right? And so here, for example, in this Chinese study with gefitinib, you can see up top that there's definitely a disease-free survival benefit. But when it came to overall survival, there was no benefit. So in fact, we were kind of really kicking the can down the road. But the question again got brought up with the ADAURA trial. That's why we were so eagerly anticipating the overall survival, because we knew we were going to see a DFS benefit, which we did. We didn't expect to see that much of a DFS benefit. And the simple fact is osimertinib is a better drug, right? And so then thankfully, it translated to the OS benefit, and now it is standard of care in the adjuvant setting for these patients. Now, the question that we're constantly asking as medical oncologists that are getting the sequencing data, this molecular data from the early stage tumors, where we're picking up these mutations, is can we extrapolate ADAURA findings to other mutations? It's very attractive. We want to do it, but it's not that simple, because you have to think about it. The mutations, the drugs, they all have different risk-benefit equations, right? Toxicities. Osimertinib is very well tolerated, right? Other, ALK TKIs have many more different side effects that we have to do constant dose adjustments and so on. So for someone that potentially is cured already and has no evidence of disease after surgery, keeping them for a prolonged period on this TKI that's causing these side effects is kind of a hard ask as well. Then the benefit side, biology, we're not sure. We see the ADAURA data, we see the curves, right? We see the benefit, but Dr. Flores brought up, is it curing? There is this chance that while in the metastatic setting, we're fairly sure that it does not cure, because you stop the TKI, the cancer is going to come back. in the early stage setting, there's data and there's potential biology that says that whenever the tumor is at its very, very lowest level, that these TKIs can be more effective, and it might be potentially leading to a cure. One thing that is very true is the CNS benefit of some of these TKIs. Osimertinib has great CNS penetration. So in the DORA trial, they showed that the CNS recurrence rates were significantly lower, and that's an important fact. And then finally, just efficacy. Look, if the TKI is not that effective, it's not going to have a place here. But what happens for ALK TKIs that can work for years, right? It potentially might also not have a place in the adjuvant setting, because then the OS bar is going to be super high, because these patients, when they recur, are going to do well for years anyways. And so it's really a tricky equation here. Now, so rare mutations, I thought, I would just like to give an example of kind of how we consider this problem. And so thinking about EGFR, but the atypical mutations, these make up 10 to 15%. So these are the non-exon 19 deletions and 21 substitutions, all the rest. And so this is really highlighted by the exon 20 insertions. These are the most prevalent amongst them. Then the other group is these major atypicals. These are 3 mutations spread across 18, 20, and 21, and where they do have an FDA indication of a second generation TKI. So very briefly, we don't need to go into this, but these exon 20 insertions, they're quite common. They're more common. They have the same clinical phenotype that we see the other EGFR mutations, but they're highly heterogeneous. And these mutations don't impact the ATP binding pocket, and therefore are not sensitive to classical TKIs. But there are new drugs that are just recently approved that we're very excited about, because we were never able to target them. Now, the amivantamab is an IV drug. It's a bispecific antibody that targets EGFR and MET, which is the next door RTK. And essentially, it's an IV medication. It's given weekly for 5 weeks and then once every 2 weeks afterwards. This is data from the CHRYSALIS trial that shows, just paying attention to the efficacy. The response rate's 40%, median PFS 8.3 months, and duration of response 11.1 months. But look at the toxicity, infusion reaction. We usually get them over this, but it's a big deal. It happens a lot of rash, a lot of skin toxicities and diarrhea. 35% grade 3 or more AEs. Mobocertinib is the other drug that's approved now. It's an oral drug, which is good. Overall response rate's only 28%. The ones that do respond really respond, but again, look, 91% of patients get diarrhea with this drug. There are newer TKIs in this space that are coming up that are much more specific to the mutant versus wild type, which we can expect better efficacy and better side effect profiles, as well as we're designing drugs that have better CNS penetration. These drugs might actually find their way into the frontline space. And then finally, just these major atypicals really respond quite well to second and third generation TKIs. So we're always kind of asking ourselves, do we really put patients on this where it's not a really standard, typically in the metastatic setting, but it is, again, very attractive. I'll skip this. And then we had already discussed the current trials really trying to answer this question of the other TKIs. And then with that, I'll end with these conclusions. Thank you.